Kia ora koto. My name is JT, Dr. Jagadish Thakur. I'm a senior lecturer at the University of Auckland in New Zealand. I'm very excited to present along with my colleagues, Dr. Lucy Richardson and Associate Professor David Holmes from Monash University, our research on COVID-19 vaccine audience segments in Australia. So the motivation for this research was that a popular public health adage, it's not vaccines that save lives, it's vaccination. And given the unprecedented scientific progress in identifying and giving the humanity a COVID-19 vaccine, there are still challenges to get people vaccinated against this deadly disease. One of the ways that health communication scholars and science communication scholars advise campaign managers is to understand audience through audience segmentation method, where we try to group people based on similar characteristics. Usually it is demographic, geographic, but most importantly, it would be psychographic, the public's beliefs, attitudes that actually make up for better segmentation. Prior studies did have included audience segmentation, but most of them on COVID-19 safety behaviors rather than vaccination per se. There are some studies on vaccination, of course, but there is a lot of measurement variance when it comes to what are the variables that are used to identify vaccine segments. For example, some studies use only attitudes, while some use intentions, some use norms, while others use trust in different sources of information. So this gives rise to invariance in measurement and inability to cross-check how these segments come about in different countries. So we used one of the most powerful and actionable theories in public health and human action, the theory of a planned behavior, which says that the attitudes, social norms, perceived behavior control, and behavioral intention play a big role in predicting human behavior, including in health communication. So just to give a background, Australia has been one of the few countries in the world that have successfully controlled the spread of COVID-19, as well in that process saved many lives. As of mid-April, World Health Organization reports only about 6,000 deaths in Australia. And it's not only because there's still 6,000 lives of family members that are lost. And I'm sure very few people in the world who haven't been directly affected or knowing someone that has been affected or even died because of COVID-19. In Australia, there were other processes as well. One of the difference in Australia and other countries was the difference in the federal and the state response. And sometimes there were concerns about AstraZeneca among certain populations. So in spite of that, I think there's been a really good response. So we used a nationally representative sample that we got from Qualtrics panel, and we conducted this survey exactly last year when there was a resurgence of COVID-19 infections and deaths in Australia, partly due to the rise of the Delta variant. We used 16 items for segmentation instead of using just a couple of items. We asked people about their attitudes, affective and cognitive. We asked all three kinds of social norms, subjective, descriptive, and injunctive social norms. We asked about perceived behavior control and intentions to protect, to get a vaccine to protect themselves and to protect others or those who are more vulnerable. Most of these measures have been picked up from previous surveys. We used latent class analysis, and I've tested 2 to 8 segments, and we found a 5-segment solution to provide a better way to understand and explain the different audience segments in Australia. What we found is that the biggest segment in Australia are the vaccine enthusiasts, and they make up about 28% of the population. The vaccine supporters are slightly less enthusiastic about getting a COVID-19 vaccine. The 3 other groups, the vaccine socials, hesitants, and skeptics, are probably of more interest from a science communication and health communication perspective. So I'll be focusing on that. The vaccine skeptics have the least favorable attitudes towards the vaccine. They perceive weak social norms, and they say they overwhelmingly say that they don't want, they're definitely not going to take a vaccine to protect themselves or the others. They tend to be female, between 29 to 49 years old, with a peak at 30 to 39 years of age. After the segmentation, or after the questions that we asked for segmentation, we also asked people to select reasons why they choose or decline getting a COVID-19 vaccine. So among vaccine skeptics, we found that the primary or the most frequently mentioned reason was fear of getting infected due to the vaccine, and pandemic being not as serious as experts say. The vaccine hesitant, about 15% of our sample, they have less favorable views. They are a majority who say unsure, but leaning towards no, to get a vaccine to protect themselves or others. They tend to be female again, 20 to 49 years of old, with a peak at 20 to 29 years of age. Unlike skeptics, they provide different reasons not to get a vaccine, including vaccine side effects, the speed of vaccine development. They need more time to ensure the safety of a new and untested technology. We found one of the most interesting segments, and probably one of the interesting contributions of this study, is a segment called vaccine socials, who, only a minority say they definitely will get a vaccine for themselves, but over a third say that they will get a vaccine to protect others. For this segment, at least, the primary motivator to get a vaccine is to protect others, the vulnerable, the family and friends who are more at risk of getting COVID-19. They tend to be female, again, between 29 to 49 years of age, with a peak at 20 to 29 years of age. Surprisingly, compared to vaccine skeptics and hesitants, socials do not provide many reasons at all to either accept or to decline a vaccine, indicating that they might be sitting on the fence. Apart from vaccination intentions and measures, we also asked them about trust in various sources of information. What we found was that across different sources of information on health experts, scientists, government officials, vaccine socials, hesitant, and skeptics generally had lower levels of trust. Most interestingly, among vaccine skeptics, they generally have high levels of trust on family and friends and their local doctor or general practitioner. Similarly, across different sources of information, trust in information channels, again, the skeptics and the hesitants had real low levels of trust in different sources of information. So the main important takeaways from our work was that, firstly, there's a debate whether altruism messaging works or doesn't work. And segmentation analysis, such as our study, helps us identify that it works with a particular segment called vaccine socials, who may make up to 20% of the population of a country like Australia. Skeptics and hesitants have different reasons to accept or decline a vaccine. Therefore, providing them more personalized information would actually help. Socials do not list a lot of reasons to get or reject a vaccine and might be sitting on the fence. Using medical experts, general practitioners, or local doctors might be more influential way of trying to reach the audience that are skeptics and hesitants. Targeting altruism messaging for vaccine socials might work. Hesitants might need more personalized information about safety, compatibility, and rigor that goes in testing and approving a vaccine. Skeptics might not be reached at all with more scientific information and from scientists and medical experts, and certainly not from government agencies. They probably will be more effective if we reach them through more localized information networks of family and friends and local leaders. Thank you so much for your time. And we look forward for your questions or any suggestions you have about our research. Thank you.